I would like, on behalf of gIDE, to welcome and to open this Zoom meeting, this special Zoom meeting with our Australian experts. And for me, it's a big pleasure because when we are in Australia, I enjoy very much the fact that we have a long-lasting team of experts, friends, and in this very relaxed atmosphere we create when we have these informal meetings, we talk about all different things, but also about the latest trends in dental thing, what in the dental world, what is important, what is not important, how do you see this? And between the three of us, and if Glenn is there, the four of us, there is always a very honest exchange of information. And this is what I appreciate so much. And this is how we fine-tune the program also for the future. So therefore, it's so nice to have this discussion going in the next hour. So Chris, what about the latest trends? Where can we start? What does David think about? I don't know, digital dentistry. How far can we go with the DSD in our planning and our workflow? So. Chris, where do we start with this discussion? What do you think?
Well, I think aesthetic dentistry has morphed into more minimally invasive dentistry. I think in the past, there was a lot of conventional crown and bridge work and a lot of preparation of teeth. I think we're really more focused a bit more on minimally invasive dentistry in my practice. Additive types of dentistry, more conservative preparations in what we do. And I know that with David, he's doing a lot of DSD, and I know he's been involved with DSD. So that is something that's really changed dentistry as well. I think that's been a very useful and beneficial protocol to use for our patients. But maybe David can elaborate a bit more on the DSD. So maybe I'll leave you to talk about that, because I know you've been very heavily involved with DSD, David.
Thanks, Chris, and hi, Egon. Great to see you again, even though you're in Africa. Yes, DSD certainly has changed the face of contemporary dentistry, and I think it's one of the paradigm shifts in dentistry. Prior to that time, we had frustrations in trying to communicate an aesthetic prescription with the laboratory and indeed with our patients. And we could try and discuss and explain to them what we would like to do or what our vision was of their aesthetic end result. And frankly, a lot of it came down to a patient trusting you. They felt trust and they would go along with you. But for many people, that often when the reality came at the time of bonding crowns, that it was an okay result, or in some cases, a not okay result. So we had to develop much better communication. And I remember even from the laboratory aspect, I'm very specific about harmony of the face and centerline harmony and midline axis of the central incisors and how this relates. And I got very frustrated with trying to communicate that with my ceramist with good provisionals and study models and photos, and still we were getting it wrong. Now, I was thankfully invited by Ivoclar to Liechtenstein to their head office, and there was a young fellow giving a lecture there called Christian Coachman. And this is right back when Christian was just starting, and we got on really, really well. He's a fantastic guy, and I think will be considered one of the greats of our profession down the track in perspective of what he's done for this profession. But in the context of that meeting, he also shared his frustrations in working at the time with in Atlanta with a very well-renowned practice and those similar frustrations. And he had developed this technique of using photographs and keynote and being able to digitally analyze and then define the requirements that could then go to the laboratory. So we could then have a much more prescriptive prescription for the laboratory. This then morphed as things went on to being able to test drive this prescription and patients being able to visualize how their reconstruction may look like. This test drive, as Christian used to say.
Was this communication on the screen or also directly in the mouse, or?
But both. They could see, but Christian was very particular to do this with images, with photographs and showing them on, blowing up, so that they could see themselves as others would see themselves. And he calls this emotionally driven dentistry. For the first time, you could see these patients excited about the treatment because they've got sort of like a tangible visualization of what can be done for them. So now going to today, I mean, we went from keynote and measuring and transferring to models and so forth. Now we do this so much digitally, more digitally, and there's an app now, a DSD app, which simplifies a lot of this process, especially for newer practitioners, but still enables the analysis. And now, to be released in August, there's a new app which has even got some artificial intelligence, which will do some of these processes. Now, there is something that concerns me, and that is that some practitioners will default their responsibility in establishing an aesthetic prescription and just sending it all and getting it processed and sent back to them. So I really believe that today aesthetics is about individuality, about personality, and there's no one case that's the same as the other. And we've got to be individually prescriptive with our cases and our patients. And I don't want a paint by numbers approach. And DSD will still allow, and these apps will still allow that, provided you put the work in. I'm sorry if I've got a bit there, Chris, and but it gives a little bit of history with Christian and where we are today. And I do think it's a fundamental tool. It's not the panacea for all ills, but it's a fundamental tool that should be in everybody's practice.
But I guess,
do you
David,
have an example? Yeah, Chris, shall we ask if David has an example of a clinical case, just to make it a little bit clearer for the participants to see what you can do with it, with this tool?
Yeah, maybe David, you could bring up a case that you could show. But I guess also, I think what you said there is very important, David. I think that I see a lot of this happening in DSD, but it's actually not the dentist doing the treatment or the planning. It seems to be the technician ceramist. It should be a collaboration between all three: the dentist, the patient, and the technician, the ceramist. But it doesn't seem to be happening that way. Yeah.
Well, look, in a way, it's a bit like, I say it's analogous to Invisalign. You know, you can do the photos, you can do the scans and send it to Invisalign and just take what they give you. Or you can know what needs to be done aesthetically and functionally and occlusally and airways and so forth, and you can work with Invisalign and get a much better prescription than what you'd hope if they just, you know, some technician does it, for argument's sake. Yeah. So it's up to the practitioner to develop those skills, to understand the fundamentals of aesthetics, and then use this, as I said, it is a great tool.
And then, sorry if I interrupt, then we have that vital point in this workflow in which we can still decide to change a lot, and that's called the mock-up, and that's where you move forward from. David.
And Egon, I think that's a very important tool, because people are looking to say the mock-up should always be good. You know, the patient, wow. But sometimes the patient goes, no, I don't like that. And this
is why you use the word test drive.
And that is as equally, if not more important than a good result, because you've got a starting point to establish that aesthetic prescription that the patient's going to be happy with. And you can test variations on that, that prescription. So that's what's important, because as I said at the start, often many patients just trusted until the case was about to be bonded or cemented. And that was the first time they got to see the case. This way, they're part of the process, that they feel involved. They're emotively connected with the case as well. Now, this is just an example of how we used to do it. And it's fascinating, you know, when you start taking images, and Christian showed this beautifully to me, and you start drawing lines or working with proportions, you start seeing things that, frankly, you didn't see before. And that's the beauty of going through this process. And doing the old keynotes, we could put these templates on and grids on, and we could start to see, you know, proportion issues, centerline issues, incisal plane issues, needs for gingivectomies or recontouring and so forth. And we can do these simulations. So this is how we used to do it. And then we could do these measurements, which enables us to take this data back to a study model and be able to establish a centerline axis, and proportioning of teeth and so forth. We could then do a guided wax up. That this data was then used to guide a wax up. Well, we don't do it that way anymore. We're a lot faster because we can use intraoral scanners and digitally do this. And so now with some of the software, here's an example of a case with this patient. We're doing these upper anteriors, and we start to do this with this 3D design, all computer generated. And then we go and do a test drive with this patient. And then, because I love working with provisionals, you know, I want to do some provisionals and test drive it and assess it further. And I want time to work with tissues and so forth. And then we can come and see how he reacts to those provisionals, and phonetically and aesthetically and lip support and so forth, not just a quick few minutes. And I think for younger practitioners, the use of good provisionals is a critical step, and it's often one where they're just seen as sort of protective until the lab can get the work back. Well, to me, provisionals are a key to successful practices. And then we can go and take this patient, making a dramatic change to his aesthetic endpoint, and one that we also minimize the risk of remakes or an unhappy patient, because we've followed, we've tested, we've confirmed, and we've gone through. And that's one of the powers of digital smile design, and especially with the newer approaches with the apps and so forth, it makes this process, especially for the younger practitioner, a lot easier.
It's very nice, David. Very, very nice. I guess these mock-ups are such an important part of the process. And I know myself, many times I carry out a case, I put these beautiful provisionals on, and I'm looking at myself thinking, wow, this is beautiful. But then sometimes the patient doesn't like it. And it's quite interesting how some patients like long teeth or short teeth, or they like different things. So how do you communicate to your patient those sort of factors? Like, everyone wants them white, but they want them natural. You know, that sort of contradicts itself. But how do you communicate to the patient some of these little characteristics about teeth that you might want to put into the teeth?
Well, that's a good point, Chris. And I think it all starts with communication and talking at the start. What don't they like? What do they like? You're starting to get some sort of feel. Do they want that American sort of, I call it, excuse me to all our American friends, toilet bowl aesthetics? Or do you want a more European style aesthetic? Can we, a lot of
sometimes the patient,
yeah,
sometimes the patient doesn't know what they want.
That's exactly right. So most patients' aesthetic is perfectly straight teeth and as wide as you possibly get them. So we've got to retrain their eye. And you can't do that going from where they are now to the finished case. You've got to train them with provisionals. And it may be even a series of provisionals as you add some character, some rotation, some variance, and you can use tints and so forth to even fine-tune that further, Chris, as you're suggesting, with more characterization, and you push the boundaries, and you may come back, you may, you know, until you find that, and it takes time. It's like I say to patients, if I take you from a blonde to a, you know, black hair, it's going to look all wrong for you at the start. It does take time for you to get used to this new look.
Yeah, so what are you saying to the patient? So when you put the mock-up on, do you get their opinion straight away, or are you asking them to come back after a couple of days, after they've got used to it, maybe shown their friends, their family?
No, Chris, they never go home with the mock-up. And we actually avoid, you know, Egon alluded to this, I think, earlier. We never give them a mirror because these are mock-ups, and they get the mirror and they bring it right up. They go, what's this little bubble here and all the rest? If you do it photographically, they can see the overall visual. This is our starting point to test and refine, and then we will go to provisionals. That's when they can go home and spend time with the provisionals. And it may be that we scan, we make changes, we do a new set of provisionals as we may be making some changes to accommodate my wants or their needs.
It takes time
and in there it's costly. You know, it takes time to do this, and it is a cost factor that if you want excellence, that's what it takes.
So how do you transfer the 2D to a 3D? I mean, you've got the 2D images. You want to explain to everyone what you're doing with the 2D to get to a 3D?
Well, in the software, we're able to create, we can, with photographs on the software, we can merge the two data points to get a 3D, you know, assessment of the case and do it that way. Is that what you're alluding to?
Yeah, I think the 3Shape has something, you know, the digital smile design, and I know they've got this real view. They can transfer the 2D to the 3D, but it's, how accurate is that? You know,
it's pretty accurate. Because you can do this for Invisalign type of situations, for orthognathics, and it's a pretty powerful tool used well. Now, the 3D software is quite complicated to use. So most use the 2D and send it to the DSD processing center and get it converted, the files converted to 3D.
Yeah.
And then about materials, because there are different materials involved in this workflow. So you have the final product, but also the provisionals are made of different materials. What is your normal choice of materials for these different steps?
Well, we've been playing around with some GC printed provisionals, and then we'll use different glazings and tintings and so forth. My initial provisionals are a Luxa Temp. I like Luxa Temp. I use that just as my starting point provisionals, and then we're going to CAD/CAM milled materials. But we've been printing some GC type materials. That's where we're using at the moment. What about you, Egon? What are you finding?
Yeah, well, I think, of course, in the end, it's very important to follow a project, to modify it, to fine tune it, and to go in the very end, copy and paste of a certain shape and color. I still think the shape is more important than the color itself. And yeah, well, for the final restorations, milling, of course, is a great tool. And yeah, I wanted honestly to hear from you both. Do you go monolithic or monolithic only in the posterior, or can we do everything monolithic just with some surface color? Or
yeah, well, it's one of my favorite subjects, which is material science. So
yeah,
let's go back to actually minimally invasive dentistry, because that's been able to be achieved by a material science change, and that is the ability to bond ceramics like lithium disilicate. Now, that has been a paradigm shift, but you can't have true minimum invasive dentistry unless you're able to establish an aesthetic prescription, an aesthetic and functional prescription at the end volume. And then you can determine what is the preparation, the accurate preparation need dependent upon the material science, such as the depth of preparation relative to what shade change you need using lithium disilicate and so forth. So it's no use just saying, I can bond ceramic. We've got to know what the end point is and then be able to prepare as minimally as possible to achieve our aesthetic and functional goals. Now, when we get back to material science, there is not one perfect material. And indeed, at the moment, I'm just starting a research project with Deakin University on trying to produce a better ceramic. Because if you look at lithium disilicate, it's got a flexural strength of somewhere around 450 megapascals, which if it's bonded well, that's good, but you can break lithium disilicate. It also doesn't have as much translucency as I would like, and it doesn't have what we call bling. It doesn't have that brightness. So for argument's sake, in our veneer cases, where appropriate with occlusal loading and amount of enamel and so forth, we're using a lot more feldspathic veneers. The trouble is feldspathic veneers are a beautiful veneer, but they're very difficult to do and technically, and you have to have a very accurate aesthetic prescription, because it's not like you've got an Emax, you can go back and do some modifications and so forth. You've got virtually a one hit with feldspathic. So
you have to bond them to the teeth, otherwise you cannot even touch them.
Exactly.
Much, right?
So you've got to have good enamel to work with. So let's have a look at material science. So what have we got in our armamentarium? We've got feldspathic materials, which are a small percentage of cases, like those highly aesthetic veneer cases, where we've got good enamel and occlusal loading issues and so forth are favourable. We've got Emax, which is a wonderful material that can be used as monolithic or veneered. We've got zirconia, zirconia oxide, which can be monolithic or veneered. And we've got some modified zirconias, which instead of a normal flexural strength of around 1200 megapascals come down to about 650, with changing either the yttrium oxide level, it's normally around 3%, so they can modify the level of yttrium oxide, or even some glass infiltration to try and improve the translucency and match Emax, which in my book is still not great. So I'm trying to develop a ceramic which will be as strong as zirconium oxide, with translucency closer to feldspathic and with that bling like we used to get. I did in the 1990s Matt Sanderson, when he was developing Procera CAD-CAM technologies, we did a replication study and producing copings with CAD-CAM, and we used alumina, and alumina was a beautiful crown. It really had bling. It had great aesthetics. In fact, it's one of my most favorable aesthetics. We can't get alumina now.
Yeah. Okay.
Sorry, what do you think,
no,
Chris?
Then,
Egon, what are your thoughts on it?
No, I think you covered pretty well the whole topic. I don't know, Chris, do you want to add something, or shall we move on to a surgical?
Yeah, I think I'll just add one more thing. I mean, I think feldspathic porcelain will give you the best aesthetics. I think everyone will agree that aesthetically that is going to be the most pleasing, because you can build up and layer a restoration with the different colors. So it's not a monolithic block of color. But probably the disadvantage is if you don't bond it well. And if you don't have enamel, to bond to, or you don't have a substrate like gold or zirconia to bond to, then it's not going to be so effective, long term, because it is a weaker type of ceramic. Are you still doing some feldspathic or layered zirconia, or you now doing monolithic zirconias? But maybe I'll ask Egon, are you still layering your zirconia, or?
Yeah, but for a different reason also, which is maybe nice to edit right now. In the hands of my technician, there is one feature that is a little bit difficult to obtain with zirconia and lithium disilicate. That's the surface texture. If we talk about hand polishing, the micro and macro texture, so we move the surface by hand polishing. Feldspathic porcelain is still, the state of the art if you want to get that particular light reflection. So especially on the younger patient, it's really important to have not a mirror-like polished surface, but movement, micro and macro texture, like scratches and depressions in that surface. But of course we're talking about high-end aesthetics. So for me, the anterior area still is layered. And if there are areas in which lateral guidance or protrusion movements, I don't mind to have the incisal edge or the palatal cusp monolithic, but where I can, I would like to layer the vestibular part of the restorations in the static zone. Posterior monolithic is much more reliable, and aesthetics are less important. There has been a lot of improvement in monolithic aesthetics as well. But
what are you doing for full arch cases then? Like for full arch cases, are you doing layered zirconia? Are you doing a monolithic zirconia? I know David's doing monolithic zirconias with titanium bars, as am I. But
cases now, Chris.
We're talking about we're going to implant cases. What are you doing now, Egon? Are you doing monolithic zirconia, or you're doing like individual crowns on a bar? Or
monolithic zirconia is probably the most reliable and strongest material. So this is what can be done, but I agree with you. You have a drawback in anterior aesthetics if you go monolithic there as well. So you can decide to layer there, but then we still have the chipping problem if we have ceramic on top of zirconia. So I've been working also with a hybrid solution, especially when there's also a pink part. Put single restorations, maybe in groups of 3 or 4, of lithium disilicate on top of a framework, and that framework is hidden on the inside of that arch we're going to make on implants, and that can be even be milled out of titanium. because you don't see that so much. The chipping problem is still there, and we try to bypass it because it's a headache if you have a patient with, you know, they do an investment like buying a new Mercedes, and then the chipping comes. So they deliver the car, the brand new car, with a scratch on it. That does not work. Also for our full arch restorations, it should be stable in time. So therefore, these hybrid solutions, they work in our hands. I say our because we work, all the three of us, in a team with a technician. So you want to do something which is pre-planned. So we don't like if we lose the form and in the end something is completely different from the provisional. So I 100% agree with David. If we have a workflow and we can start with design and fine tune it, I would like to keep it in the end. And then the material choice is really, really difficult. But for me, a full arch, if I have a lot of volume, I don't like a big block of zirconia anymore as I did like it, let's say 10 years ago. I would go with maybe even a titanium framework, and then make a hybrid bridge with lithium disilicate groups of T's. And the pink portion will be done with composite sometimes. But there are more options on the market, and it
I guess, Egon,
also with other materials.
Yeah, Egon, I've done a lot of those cases in the past, and in my hands, I found that there's been some staining around the composite or acrylic around the lithium disilicate. Have you not found that as well in your cases, or have you developed some protocol to minimize the staining?
Yeah, we had that in the past. We found a solution. Well, the staining happens because you have different thermal expansions, and there's no chemical bond between the acrylic and the lithium disilicate. So these materials are sitting one on top of each other, but there is always a micro gap, and that picks up the stain. So we started acid etching and sandblasting the margins of these restorations that went, let's say, a millimeter and a half under the pink surface. And if you have lithium disilicate can be adhesively prepared to have a good bond with the pink composite we put on top, and then the staining decreased a lot. And
one thing I did.
Yeah.
So you got one thing I've done is I've used some zirconia bars, and we actually used lithium disilicate or Emax, and we actually CAD on. We actually fused the Emax onto the zirconia so that we could actually layer pink porcelain as well, and that's worked quite well for me in the last few years. If I did these individual lithium disilicate crowns, we didn't find the staining. Obviously, it's all fused together. So that's been a very good option for the patient. Yeah.
But again, you've still got the potential chipping issue though, Chris, of the lithium disilicate. And then you've got to take the whole bridge off to service it.
Actually, I would say I haven't actually, David. I've had one case. I had a Chinese patient who, Asian people love eating crab claws, and they bit down on a crab claw and they broke one of their Emax crowns. But all I did was I actually cut that crown off, and I made a new crown to cement on, just the individual crown. So I actually didn't remove the whole bridge. I just removed the one tooth and glued it back on, bonded it back on.
Oh, right. I'm sorry. I thought you were saying that you were bonding Emax in section onto your zirconia framework.
Yeah, I was.
Individual crowns.
Yes. So I'm bonding individual crowns on.
Not like a bridge section over the. Okay, I'm with you.
I think, yeah.
Mm-hmm.
So I mean,
you can locally repair it. Yeah.
Yes. Well, that was the
I think
idea. I
we
mean,
should,
that was the plan. Yeah.
we should move on to the next topic and discussion point, because there was very an in-depth analysis of the latest trends and the choice of ceramics and, but a surgical topic. When we all know the difficulty of doing an immediate post-extraction case. And I know that Chris is very skillful in a particular technique, which is called the socket shield technique, in which Chris leaves the buccal portion of the root in place. And then he sort of squeezes in an implant behind that buccal shield. And you probably do the grafting and work with soft tissue provisionals. And then you show these cases to the participants of the GIDE course. What about you, David, or Chris? When do you use this, or what are the ideal indications? Are there any pitfalls? Because some of us might have had some troubles in these.
Well, there are some papers on this, and Marcus Hertzler originally promoted this technique, and then of late, Howie Gluckman has been a great advocate and probably been most prolific in the literature. And I think even just last month, his article came out as a review of technique and his experience. And they've learned a lot. They've changed their approach to treatment, and there certainly were quite some complications. I think this is not for the inexperienced practitioner. One, you've got to be very aware of your case selection criteria. Two, technically, I think it's quite demanding in being able to section the root and maintain that root fragment. And indeed, one of the latest recommendations from Gluckman was is reducing that labial root face of the root subosseous about 1 millimeter. So, you know, that requires some handling and technique and so forth, but certainly done properly, some of the results look very impressive. Now, I've spoken to a dear friend, a colleague of all of us, Inaki Gambarina in Spain, and Inaki is more one to say, I'm going to maintain the aesthetics and protection with connective tissue grafting as a more predictable way of treating these anterior aesthetic and immediate cases. So, yeah, I think the technique has merit, but it is not for the new practitioner. How do you feel?
Yeah, I guess if I give my take on socket shield and partial extraction therapy, I think it's a protocol that has some merit. I think it's something that is still developing. I mean, Hertzler in 2010, started this off with a dog study and showed that, maintaining that buccal shield is able to maintain that bundle bone, which is really important to stop that alveolar remodeling. So you might ask, when do I select that protocol? It's not a protocol that I use 100% of the time. It's like, any clinician, you should be picking and doing case selection. So when do I use a socket shield approach? It's when the bone thickness, the buccal bone, is less than 1 millimeter. There have been many studies to show if the buccal bone, or you look at your cone beam CT and your buccal bone or labial bone is 1 millimeter or more, the amount of resorption that happens is minimal. But if your bone is thinner than 1 millimeter, I might consider either two options. One option would be to do a socket shield approach, or the second option is like what David mentioned about Inaki Gambarina, is to add connective tissue. So when do I do socket shield? It might be for the really thin biotite, thin buccal plate, high smile line. I'll consider a socket shield. Maybe even consider a socket shield for adjacent implants. I think with adjacent implants, that's always been the holy grail to get papilla. So maintaining a buccal shield may actually help in those sorts of cases. And I'm not sure what you think about that, Egon. I mean, for an adjacent implants, it's been very difficult to get that papilla, that full papilla with complete infill. So that socket shield may be an approach for adjacent implants.
Yeah, I think that's a good point. So you were talking about well, first of all, I think we all three of us agree it's not a technique for beginners, but if it works, you bypass a lot of other difficult procedures like GBR or soft tissue grafting, because the buccal volume stays where it is, right? Now, volume.
Yeah. I guess I should add a few things. Socket shield, you cannot do the socket shield if there's mobility in the tooth. If there's mobility in the tooth, or say there is the shield is loose. If you as you prepare the shield and you try and remove the tooth, if you have any movement of the shield, then that you'll get a complication. And I think David also mentioned about the possible complications. What are the complications with socket shield? Things like what they call external shield exposure or internal shield exposure, where you have part of the root getting exposed in the soft tissue. It's normally because you haven't prepared the shield enough. Some of the protocols have changed. In the past, the protocol was to leave the root 1 millimeter above the crest. Now it's changed. Yeah, now we're reducing it down to the osseous crest. This is some of the, what Gluckman's written about. And even the shape of the shield, instead of having the shield as a flat butt joint, having it slightly concave to allow a little bit more room for soft tissue. I think those sort of factors, I think we're still developing. That's why this is not an approach that everyone should use. I think this is still early days, and I think you have to be an experienced clinician to use that. Because one of the most difficult things is actually taking out that tooth. Removing that root is quite a challenge to get that tooth out carefully without removing too much bone and without disturbing the shield as well. So I think that is one of the difficulties.
Okay, so there are pitfalls. Very good. Then there's a personal thing. I'm putting a lot of emphasis on the last couple of years is if we work and we all have a lot of experience and we want our cases to be stable in time. So I've been working with a zero bone loss recipe, a protocol. I'm curious to hear of my friends here. What do you personally do to keep crestal bone level stable once you've placed an implant? Maybe David, you would like to start?
That's a big topic because it's not one silver bullet. It's multifactorial. It goes to the type of implant design. It's how it's placed within the socket. It's the contour. It's the use of connective tissue grafting. I'm a big advocate of connective tissue grafting. I remember Egon, we were talking about, used to present that, and Van Duren, Eric Van Duren, the O-ring seal, the connective tissue O-ring seal, and that in the design of our provisionals, how we can build this O-ring seal, it's non-contamination of componentry. There's a lot of factors that go into that.
Okay.
Yeah, I think
like biomaterials, go to zirconia abutments and so forth.
Okay. I think the studies, zero bone loss is a concept by Thomas Gavicius. And I think that, his main, I'd say, objective was about tissue thickness. And I know, Egon, you're very careful with the maintaining tissue thickness. I know David as well. But I think that's really one of the keys, having sufficient tissue thickness. And it's something we didn't really realize in the, I think we used to focus on bone.
Beginning,
Yeah, and now we focus more on soft tissue. And I think the soft tissue is what makes something stable over the long term. So I think, having the platform switched implant, having a narrow abutment, like David talked about, the sort of the abutment design has changed as well. I think the abutment design is more concave. It's not as flared as it used to be. So I think that's made a big difference. But then again, you know, while we're talking about now, I think about all these titanium bases that people are using.
Yeah.
You know, the titanium bases are probably too big. They're too wide. So I do have concerns.
Provisional crowns from, or even definitive crowns from laboratories, and you know, their concept is developing an emergence profile like a natural tooth root.
Yeah.
And that's quite the opposite.
Wrong.
That's quite the opposite of what we're trying to achieve. And we're under contouring, and the transition line of the labial face to the submergence zone is actually quite sharp. Otherwise we get a rolled edge and the soft tissues will never be sharp and sit up. We've got to have that sharp transition angle coming to a very concave surface. So we developed this with using provisionals and training the soft tissues, or as an American prosthodontist, Robert Winter said, it's the papilla is like a fluid-filled sac, and we can push it around and move it around until we develop that ideal profile.
Yeah, it's a good analogy. I like that analogy. It's like a balloon full of water. You can push it here and there and get it to the right shape.
Yeah.
Yeah, so soft tissue is definitely also necessary to be, it has to be thick enough to host the biologic with, and to compensate for a lesser amount of blood supply we don't have around our implant supported restorations, because we should not forget that between natural teeth, most of the blood supply, or a very important part, is coming from the periodontal ligament into, for instance, the papilla area. We don't have that, so the only way we can compensate with is to have more tissue. Yeah. So our restoration, if I say this, what's your opinion, has become more like a pontic on a stick.
Yeah, yeah, a mushroom, more mushroom-like.
Yeah.
You know, Joseph Kahn did that series and produced that, you know, when these crowns on insertion look so beautiful, and then down the years, you know, the contour's gone, the soft tissue contour is poor. So that was a very important study by Joseph. But to me, what Anaki's done with soft tissue, that I think is very important. And today, most cases are grafted, connective tissue grafted. We need more. It's better. We can never have too much. Easy to stop.
And then Chris, if you have to choose a tie base, what are your criteria? Where do you put the transition titanium zirconia? Close to the bone, higher up? What do you do with the zirconia? You polish it, you veneer it? Can you give guidelines to the participants?
Well, I guess I don't like titanium bases so much. I have had a long history with these, and even just the other day, I received a referral for a loose implant crown. And the loose implant crown, the dentist had stripped the screw as well. So I had to remove the stripped screw, but it wasn't the screw that was loose. It was actually the crown was loose from the tie base. So I think there's a few issues there. Where one, we are introducing another source of error in that we're relying on cement to hold onto a tie base. Now, some of these tie bases have definitely evolved and they've developed and they're much better than they were in the past. But I've seen several tie bases come loose, especially with long anterior crowns, where, you know, a lot of like crown, the ratios is too much. So there's a lot of leverage. So I've seen a lot of that come off. I like the ASC connection, the no bells connection, where it's, you know, screwed down. It's not relying on cement to hold something in.
Glue.
Yeah, I just don't like the glues that are used. So for me, I always try and prefer custom abutments if possible. Now, I think if
you want to see one of those ASCs, I think I may have an image here.
Yeah, maybe you can show that. I guess ASC is only a no-bell solution, and I know Straumann has a cement-on tie base, and you say what should you do with a cement-on tie base? I think you don't have that much control over how thick you can make it. I think that's one of the issues. The zirconia has to have a sufficient thickness to cement on the tire base. So sometimes the zirconia abutment is a little bit wide as it emerges from the soft tissue. So if possible, I would prefer that to be slightly higher if possible. So I would use a cup that's a fraction higher. If that answers your question.
Those tie bases, if you've got an angulation issue, then they've got to be cut at a chamfer, which then you lose wall height and then you lose retention. This case here, a single tooth case, is the provisional, and you could see the augmentation of the soft tissue there. If we just go back to now, it's got that sort of balloon effect, which enables us to move it around. Now here we see, I don't have a pointer, but you see what Chris was talking about. This is an ASC abutment. This insert goes into the zirconia of the crown, and you see the submergence contour, this concave going up to quite a sharp transition zone to the labial. And this screw connects, this is not cemented, this insert, this screw connects the crown to the insert to the abutment, so it pins it in one piece. And so you can see the only negative I have about these ASC abutments, and I think they're beautiful and for bridges as well, is the size of the access screw opening. That's the negative there. But, you know, we can see this crown now, and we can correct angulation, and, you know, you can get some very nice sort of aesthetic results. Now, I'm looking at that and I'm critiquing this at the moment, and I'm going, you know, that crown, the zenith is wrong on that crown. I need to actually go and recontour those soft tissues. If you see on the patient's left side, it's got a nice zenith. This is too round. So it's interesting when you start pulling up your slides, you start seeing things and critiquing them. But that's the beauty of doing dentistry and documenting your cases and sharing them. It's good.
But we can still pass this case, David, so don't worry.
I guess one of the issues though with these angle screw channels is that you do not get the same preload on the screw. So your tightening torque of 35 is not actually 35 because you lose some of that torque with these angles. I mean, but I have not had any come loose, David. Have you had any come loose, or Egon? Have you seen any of yours come loose?
Chris, your point is well made, and I can think of only one first molar that did loosen, but no anteriors. It was a first molar case, and that was it.
Yeah.
Okay. Do we still have sound? I hear very well everything.
I'm hearing you well too. I think we got a message that someone's lost sound, but I think we should try and open up the floor to others as well. I mean, are there any questions from the group that maybe someone wants to ask some questions, or they might have a real curly question? Maybe ask David. He'd like to answer those curly questions.
Thanks, Chris.
Could I ask a question, please?
Jonathan.
Yeah, Jonathan.
I would just be interested to know, I was listening to Professor Howes last night talking about coaxial implants, and I wondered if the expert panel might like to comment on the pros and cons of using coaxial implants to correct angulations.
Well, Jonathan, I have done some of these, and they are a little tricky in placement, in getting the orientation right at the time of implant placement. So you're having to visualize and check and so forth, because a rotational error changes things quite considerably, but they certainly can do the job. Frankly and personally, I find the ASC type approach with the angulated screw channel gives me greater flexibility, but certainly that coaxis is an option.
The comment that he made, and I use ASC and have done for a long time, and I do like it, but he did make the point from research that they've done at Sydney Uni, is that the torque that you do generate was mentioned before, I think by Chris, that the torque you actually generate is not actually the torque you're getting. And then it becomes a question whether long term that presents a problem. And that's why I think he developed a coaxial implant.
Yeah, I'm using an evolved system which is called the AXIN. That is an angulated system in which the you have to. Okay, thank you for muting the phone. That's a system in which you put the torque. The screw goes in the tie base. The zirconia is placed on top. So the channel in the zirconia is only for the driver. And the ASC is different because the screw goes in a bigger hole. Then it has to rotate in the zirconia. And then it engages in the threads in the implant. So we have been using this elegant angulated screw system, but I have to agree there are some micro movements between the tie base and the zirconia. So the activation of the tie base is with wings that clamp the zirconia in place. So there's no cement. But it's still sort of a compromise. Angulated, how did Jonathan call them? These implants, they bypass that problem, of course, but it's also difficult to choose the right implant for the right case. And then once the implant is in, you have to work with.
The thing that
Southern Implants has this system? Or?
So this is Southern coaxial.
Yeah.
Yeah. I think the other problem with these coaxial implants is that these screws, you know, I've had 2 cases come in the last couple of weeks, and then the dentist has actually damaged the screws because I don't know what they've done, but I think they've used a normal screwdriver on an angled screw, and they've stripped the screw. And I've had this happen twice now in the last 2 weeks. So I think you got to be very careful, you know, like the instructions from the laboratory, they have to be really careful because once you damage a screw, it's a pain to take out. I mean, it's a real pain. But I think the coaxial implant, I think it's a good implant. I think it's been around for a long time. To answer your question, Jonathan, the only concern I have is, you know, some people discuss about the actual angle of the screw coming at an angle. It makes the wall thickness a little bit thinner where the screw is. Now, whether that causes fractures, I don't think that's reported in the literature, but I know that's been of some concern for some dentists, that the actual where the screw is coming at the angle makes the wall thickness. And if you look at the screw itself, the screw is shorter. A Southern coaxial screw is actually a shorter screw than a normal straight conventional implant.
Especially so, the platform too.
It sure is.
Sorry? Yeah.
Then we are now almost over the hour, I think.
Let's go
and
quickly.
Before we
we had a question from Glenn.
Glenn, so we can take that question, of course.
The question is, hi everyone. Great pontificating so far. Would you like to comment on the one abutment, one time concept?
Yes, happy to do so.
Overtime.
So maybe explain what that means first, because not everyone might know what that means. Do you want to talk about what that actually means?
One abutment at one time has been developed by Bernard Toiti and Eric Rompen, and it's an interpositional element or abutment to be placed at the time of surgery so that there is no damage to the connective tissue interface just above the osseous level, as you may remove a hearing abutment or indeed a provisional crown. Now, I see, and I have utmost respect for Bernard Toiti. He's a very good friend of mine, but it brings the restorative platform up a lot higher, and it therefore makes the emergence profile much steeper and more difficult to establish. And it also, you cannot get the angulation type of corrections with your type of prosthesis. So there are others, but there are a few to start with. So
okay,
I would.
So we moved away from this personally.
So to me, in the aesthetic zone, they're a nightmare in the aesthetic zone. Maybe in the posteriors, but I think we can establish other ways of achieving the same goal. But in the aesthetic area, I think we've established in this conversation tonight that we really need to develop soft tissue profiles, the fluid-filled sac technique and so forth. We're moving, we're idealizing the emergence profile. We can only do that with having one, more soft tissue, and two, a provisional that we can modify and mold and shape and push these soft tissues over time to idealize that. Now that implies that we've got a screw retained provisional that we can take on and off and modify. Now personally, I have not seen a problem with bone levels with regard to that technique. Egon, would you like to discuss that?
No, I think I agree 100%. We have to work, of course, in a very clean way. And if you use provisionals, use titanium cylinders and not any kind of plastic or PEEK, and don't go too deep with the acrylic, and work in a clean way. The new trend is to work with some kind of intermediate abutment, like the On1, or an intermediate abutment that brings the platform, prosthetic platform, a little bit farther away from the bone. And that abutment can be quite narrow, and that makes it even more safer for the clinician who does the prosthetic part, not to disturb the bone. Of course, the fine-tuning of the emergence profile, it happens more in the superficial area than in the deeper areas. So this is why this intermediate abutment is a hot topic right now in the last couple of years, and many companies are working on that. One abutment one time and have everything ready at the time of surgery. I think we all moved away from that a little bit.
You talked about working cleanly. How are you cleaning your abutments before you fit them on? I mean, we're talking about this one abutment one time. What are you doing to ensure that it is clean? How do you clean your abutments? How do you clean your restorations before you fit them down onto an implant? Obviously, you know, these are temporaries, or you're getting it back from the laboratory. It's not a sterile. It's not a sterile abutment.
No, it's not sterilized. It should be cleaned in one way or another. You can use steam cleaning in the laboratory. You don't mix the laboratory screws with the clinical screws, so the new set of screws. And also, if you're clinically are working on an abutment, don't put it on and off and it's dirty and you use rubber cups to polish or to modify something. Use some soap, ultrasonic cleaning, or there are even special devices like the plasma cleaning. But you have to do something, and don't use the alcohol without rinsing. So, and then every time you take a restoration of a patient, if you want to work on that restoration, making a modification, like David said, put the restoration on an implant analog. So the part of the connection is protected while you're grinding on your provisional and modifying an emergence profile. So all these little things together are helpful, and then
Yeah.
the bone will give us the price by remodeling.
But it's funny. It's funny that we have not developed a consensus or a protocol for how we clean our implants or clean our abutments or restorations before we fit them in. I don't think anyone's really talked about this.
But that's no reason not to do it,
Yeah.
not to clean it.
For sure.
Well, everyone,
for sure.
Just wanting to let everyone know, we've now gone 10 minutes over. Certainly an amazing, lively discussion, but maybe just time for final comments, unless you wanted to add anything else.
Yeah, I think maybe our Australian colleagues, does anybody of you know exactly the point of our Master Clinician program with session 3? What are the prevision? When is this going to happen? What's the planning so far? Because I did not follow this after session 2. I was sort of stuck here.
I can help here because I'm on session 3 with
yeah.
Sasha, and we're running that in January at this stage.
Okay, postponed.
2021, which hopefully international, flights will be available, but we don't know. We don't know. But at this stage, it's January, late January.
Okay. Then I think it was an interesting discussion, and I'm very happy you brought up very trendy topics, and for sure this will be put in practice in Australia. So I personally cannot wait to be back for an informal dinner with you, you two, and I can't wait to see you and to hug you physically. So
Thank you.
We won't be doing an elbow bump with you.
Okay, yeah.